In this section, we're going to discuss about diseases that can lead to epidemics. And we will start with an exercise. We're going to show you different diseases, and I would like you to choose the ones that can convert into epidemics. And we call those the diseases, the epidemic-prone diseases. So yes, we talk about these diseases when they tend to spread throughout a given population very fast. And of course, there are very many diseases and there are very many examples of diseases, but we're going to describe in this section the most common ones that humanitarian interventions are happening today. We are intervening in a lot of epidemics of measles, of cholera, meningitis, filovirus, which are categorized inside of the viral hemorrhagic fevers, which are Ebola or Marburg epidemics, malaria, and COVID-19. And of course, the severity are very, very characteristics of each of these diseases. It's not the same, as you may know, the severity of Ebola or Marburg as the severity of cholera cases. In case that we intervene very fast, the prognosis and the severity attributed to the disease are completely different, and the case fatality rate is completely different in the different diseases. So we will discuss about these different aspects. We can think about other diseases like dengue, yellow fever, etc., etc. But as I say, the most common ones that we intervene in are these ones, and we will discuss about a little bit about them. So what is the difference between epidemic and pandemic? So in epidemics, what is happening is that a lot of cases are happening from a specific disease in a certain moment of time to a lot of people, and it's affecting in the same region. Whereas a pandemic, this disease is happening in crossing the borders, and it's spreading worldwide of a new disease. So we can have the disease located in a region or a country, and then it can move globally fast and affecting in a large scale of people massively. And we will start describing diseases like measles. And measles, you understand, and it's really a common disease that is in all the world, and we know it quite well. But it's very different when we see it in our places where we live, or when we do interventions of outbreaks of measles. So what is measles? Measles is an acute, highly transmissible viral disease. The reservoir is the humans, so the only transmission route is from person to person. And it's the way it's transmitted is the direct contact through nasal or throat secretions. It's an airborne disease, so it's very contagious. So if you are in a room, you have a lot of possibilities, if you have an infected case, of transmitting it and infecting the rest of the kids around you. The contagious period of measles is around 3-4 days before this specific characteristic rash in the skin, when it shows and appears, and it can last up to 5 days after this rash begins. And the case fatality rate in developing countries is from 3 to 15%. In Europe or in places where you have regular activities and preventive activities, the case fatality rate is really low. But in countries where you don't have these possibilities, the case fatality rate is going a lot higher, and even up to 20% in emergency settings. So depending on how the conditions are in refugee camps, or where you have very poor hygiene conditions, this can go very high in terms of mortality. And this is one of the good things about measles is that once you get infected, you get a lifelong immunity, and this is very positive. You cannot be reinfected again. And another very positive thing about measles is that you can have a very effective vaccine with only one boost, meaning that you can do and plan vaccination campaigns when you have an outbreak to try to protect the rest of the communities affected in those cases. But still a major public health problem, because we've seen, even though we've got the tools like the vaccines, and even though the immunity is a lifelong immunity, we're still seeing very many outbreaks in different settings in Africa, in Asia, depending on the humanitarian context, and it's due to lack of access to vaccination programs or lack of access to healthcare in general. So that's why we are constantly responding to measles outbreaks despite the efforts of eliminating the disease from all the WHO and national policies of countries trying to reduce it. The second disease we're going to talk about is the meningococcal meningitis. This is a disease that is called by a bacteria with different serotypes, and the humans are the only reservoir. The transmission, therefore, is from person to person through respiratory droplets in the nasopharyngeal area, and majority of the patients are coming with high fever, neck stiffness, intense headache, nausea, vomiting, and other symptoms. Other patients, and in a smaller proportion, can really become very severe with neurological sequelae and other complications leading to death. So the problem with meningitis is that if you don't have proper access to healthcare, the case fatality rate can lead up to 50%, but with proper treatment, the case fatality rate can be reduced to less than 10%. So where is this disease located? So this is normally happening in the meningitis belt, as you can see in the map. That goes from Senegal up to south of Mauritania, Mali, Niger, northern Nigeria, Chad, up to Ethiopia. And all these countries affected, what is happening is that they are suffering from this meningococcal disease in waves of epidemics every 8 to 10 years. The onset of these epidemics are happening from December to February, which is the dry season. This is the moment when there are the winds are very dry, and the droplets in the people infected are transmitting faster the disease. And it ends with the rains. So when the air gets fresh and the rains come, and this is happening in around May or June, then the waves of the disease go slower, and of course also the need of an intervention needs to be fast in time at the beginning of this dry season. As mentioned, there are different serogroups of these bacteria. Majority of the outbreaks, historical outbreaks, were with Neisseria meningitidis serotype A. There's been massive efforts of different countries and WHO and different international humanitarian NGOs to do mass vaccination campaigns in all these countries. But of course, the protection of these vaccines are around 3 to 5 years. So we can expect also and always in this meningitis belt of sub-Saharan Africa, recurrent outbreaks along the coming years. We've been seeing also different epidemics due to other serotypes, which are very virulent, like the recent outbreaks of Nigeria, of meningitis C, and W135, even mixed epidemics. We're going to continue with COVID-19. You're more familiar with this disease because it's one of the examples of the pandemias, and it's been spread all over the world. And as you know, it's an infectious disease caused by a virus of the family of the SARS, and it's been discovered as coronavirus. Majority of patients can be either asymptomatic or they develop mild to moderate respiratory disease symptoms, and they require really without requiring special treatments. The issue with coronavirus is the people at risk. That can be older people, more than 60 years old, or the people that are suffering from chronic conditions, cardiovascular diseases, respiratory chronic diseases, cancer, diabetes, etc. And they can develop a more severe illness that can require intensive care unit and intensive care units and hospitalizations up to 20%. The transmission, again, is from person to person. These are respiratory secretions, the respiratory droplets in the air, and the distance is around 2 meters to reach these respiratory droplets that also land into the surfaces. This is why we insist so much on the physical distancing of these meters of distance and all the hygiene and prevention and infection and control measures like wearing masks, social distance, etc., etc. And the transmission can be before you develop the symptoms, and even few days after healing can be also possible that they are transmitting the disease. So it's a very difficult disease to control because you've got a lot of asymptomatic people in the community that we don't know if they are infected or not. The incubation period is from 2 to 14 days, and this is important to know to take the control measures. So when we want to do the contact tracing and we want to confine or lock down small areas, then these can give us ideas on what to do as well. And it's estimated, with all the evidence that has been elaborated in the latest waves, that the overall case fatality rate can reach up to 4%. Of course, we're still looking at the differences between the countries, and we will go into that detail later. This is an example of what is a pandemic. No? So COVID-19 has been spread throughout all the continent, and it's been very, very difficult to control these huge waves with huge magnitude and severity about the coronavirus disease. And we're still on the second wave now, and let's see how long does it take to finalize the pandemic. The last disease I'm going to talk about is the filovirus disease, which is classified as a viral hemorrhagic fever, and it's characterized because of the acute onset of symptoms and the severity. So where does this disease start? Well, the reservoir are wild animals living in the bush, like fruit bats or primates, and it is when the humans are in contact with these infected animals that the transmission starts. And humans become infective when they develop the symptoms of the disease. Symptoms that can be high fever, nausea, vomiting, diarrhea, and then it can complicate with severe bleeding. So, as you may know, these diseases are located normally in sub-Saharan Africa, and these can be confusing with other diseases like malaria developing the same symptoms. The incubation period of Ebola or Marburg can reach up to 2 to 21 days. This is, as I said, the period where the patients can be developing symptoms and be infective. And another very, very high way of transmission is when the patients have died and the fluids are very, very infective. So therefore, manipulating the corpses and handling patients, all the first line workers need to be super protected, as you can see in the photo with all the workers with the personal protection equipment, because the case fatality rate of this disease can reach from 20% up to 90%, depending on the serotypes And also it can get more complicated in areas like in the latest outbreak declared in Congo back in 2018 and that ended in June 2020 in a conflict area to try to reach as many patients as we can in the community and do contact tracing. So when we are working in Ebola disease, and which is very complex to manage because of the severity and the difficulties reaching and contact tracing all the patients. On top of that, if we have conflict zones like we had in the last epidemic, it's really a very challenging way of operating in this type of emergencies. To declare the end of an epidemic of this type of diseases, we need to wait 42 days, for instance, with no patients found in the areas and the regions where it was declared. So this slide is to highlight the historical Ebola virus outbreaks. You can see different outbreaks happening in Congo, in South Sudan, in Uganda, in different countries in Central African area. But just to highlight that we had a big unprecedented outbreak of Ebola in West Africa back in 2014 and 2015. And it was very specific because it affected 3 countries in the region, Sierra Leone, Guinea, and Liberia. And it was not affecting the rural areas, it was affecting the main market and commercial routes. So that's why it affected so many people. So around 22,000 of patients infected of Ebola, which was huge comparing to previous outbreaks described, and the case fatality rate was up to 50% despite all the international efforts to try to reduce the spread of the disease. There were a lot of lessons learned out of this huge epidemic, and there's been new outbreaks, as you may know, in Congo in the latest years and up to date. To know a little bit more about the history of Ebola, which is very, very interesting, you will now see the following video of killer diseases, Ebola virus.
This is the story of how my village survived Ebola. Bats brought the tiny Ebola germs, too small to see, so small, yet so dangerous. Without realizing, grandfather rubbed a little blood in his eye. Ebola germs came into his body. Days went by. Then grandfather got a terrible fever and weakness. We thought it was malaria, but he was soon much worse. He had vomiting and diarrhea. His fever got even higher. I ran to get the nurse. But grandfather had already died. I was heartbroken. The nurse thought it might be Ebola, a disease caught from bush meat, but which spreads from person to person. Others in our region had already died of this new disease. Unless we understood the disease and followed their rules, it could spread further and kill many more people. She explained that Ebola was in the body fluids of someone who was sick or had died of Ebola. Their sweat, tears, mucus, saliva, vomit, diarrhea, urine, breast milk, sexual fluids, and blood. When we touch a sick person's body fluids, the Ebola germs can get into small breaks in our skin or into our eyes, nose, or mouth. The Ebola germs spread into our body and make us sick. When somebody dies of Ebola, that body is much more contagious. No one should ever touch the dead body. The nurse advised us to wash our hands with soap and water right away. She contacted the trained burial team to help us bury grandfather's body safely. The burial team came. They comforted us and explained what they had to do to protect us. The team wore protective clothing that kept them safe from the dangerous germs. They sprayed grandfather's room and his body with chlorine to destroy the Ebola germs. They put his body safely away in a bag. To prevent the spread of Ebola, no one could touch the body of anyone who had died with signs of the disease. They also burned his mattress, bedding, and clothes, anything that might have his germs. All these actions made us safer. It was too great a risk to follow all our traditions, but we still honored grandfather in the time of Ebola. Our chief gathered all the villagers together after grandfather's death. He explained that it's natural for us to fear Ebola, but if we trust in our health workers and follow their rules, we could stop the disease. The nurse explained to us, when a person has symptoms such as fever, don't touch them. Get them to the treatment center right away. They will have the best chance of surviving and they won't spread Ebola. She advised us to wash our hands with soap and water many times a day. The whole village agreed to follow these rules. Since we all had close contact with grandfather, we were at risk of getting Ebola. We had to stay home. A health worker visited us every day to see whether we had fever or signs of sickness. We would show signs within 21 days if we had Ebola. Many days passed, and I thought we would all stay healthy. But one morning, I found my mother burning with fever. I knew I couldn't touch her. She was now contagious. My father came in. He told me he was taking my mother away to our uncle's house in the nearby village. He was afraid to take her to the treatment center, afraid he'd never see her again. I knew I had to stop them. I was young, but I stood up to both of them. I told them if this could be Ebola, she must go to the treatment center right away. We needed to trust in our health workers to save her, save ourselves, and save our village. I saw in their faces that they understood. Running away would only lead to more death and suffering. My mother tested positive for Ebola. They found her a bed. At first, the health workers looked scary, but I knew they wore the suits to protect themselves, and inside they were normal people like the nurse. They took good care of my mother. They gave her fluids, medicine, and food, and helped her body stay strong to fight Ebola. I missed my mother very much, but I could still talk to her on the phone. Sadly, some people in my village didn't survive, but my mother got better day by day. Soon, we were able to see her from a safe distance. One day, the nurse announced that my mother would live. Now we were safe to hug and kiss her. It was a day to celebrate. Our village followed their rules. We trusted our health workers, brought us sick for care right away, called for the safe burial team when one of our people died, and we always wash our hands with soap and water. Our village survived Ebola. Yours can too.
Thank you very much for your attention. And this is the end of the section Diseases Prone to Epidemics.